What's up, CyberMDs, and welcome to another USMLE Step 2 lecture. Today's lecture will cover cirrhosis. Before we dive in, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources to students everywhere. On this slide, I've simply provided a brief lecture outline, so pause here if you need that. Let's start by establishing a fundamental understanding of what cirrhosis actually is. Cirrhosis represents one of the final stages of chronic liver disease, characterized by the replacement of normal liver tissue with scar tissue and regenerative nodules. This leads to a significant loss of liver function, and that's a fact that underscores the gravity of this condition. The liver does so many things in our body. So if we lose liver function, have significant loss of liver function, there's going to be some pretty poor outcomes from that. If we turn to the epidemiology of cirrhosis, it's important to recognize that this has a global impact. Cirrhosis is a leading cause of mortality and morbidity worldwide, often resulting from common risk factors such as chronic alcohol abuse, viral hepatitis, and fatty liver disease. So understanding those statistics is crucial, and it emphasizes the widespread nature of cirrhosis and its significance in public health. Next, let's consider the clinical importance of cirrhosis as a part of this introduction. In our practice as future physicians, you will encounter cirrhosis not just as a disease entity, but as a critical complication of various liver diseases. Its management often requires a multidisciplinary approach involving careful monitoring, treatment of the complications, and often considerations for liver transplantation. In terms of your exams, cirrhosis is a frequently tested topic given its complexity and the critical thinking required for its management. Finally, our goals for today's lecture are to provide a comprehensive understanding of cirrhosis, from its causes and pathophysiology to its clinical features, diagnosis, and some general management. We aim to equip you with the knowledge and skills necessary to effectively recognize and treat this condition. So let's get started. Let's discuss some of the etiologies of cirrhosis. Understanding the causes of cirrhosis is crucial for diagnosis, management, and even prevention. First, let's explore some of the common causes, such as viral hepatitis, specifically types B and C. These are major contributors to the global burden of cirrhosis. These viruses lead to chronic liver inflammation and, over time, result in liver fibrosis and cirrhosis. Alcohol consumption is another leading cause of cirrhosis. Chronic and excessive alcohol intake can cause progressive liver damage, leading to fatty liver, alcoholic hepatitis, and eventually cirrhosis. Non-alcoholic steatohepatitis and non-alcoholic fatty liver disease represent a spectrum of liver diseases associated with obesity and metabolic syndrome. These conditions can progress from simple steatosis to NASH and ultimately to cirrhosis. Autoimmune hepatitis, where the body's immune system attacks liver cells, can also lead to chronic inflammation and therefore scarring in the liver. Now, those are some of the common causes. Let's now talk about some of the more rare causes, such as Wilson's disease, which is this genetic disorder leading to excessive copper accumulation in the liver, but also in the brain and other organs, and it can cause cirrhosis if it's not treated. Hemochromatosis is another genetic condition where iron overload in the liver leads to cirrhosis. We have alpha-1 antitrypsin deficiency, and that's a genetic disorder causing accumulation of alpha-1 antitrypsin protein in the liver, which can lead to liver hepatocyte damage and cirrhosis as well. And then we have primary sclerosing cholangitis and primary biliary cholangitis, which are rare autoimmune diseases that affect the bile ducts and can progress to cirrhosis as well. So each of these etiologies has unique pathophysiological mechanisms and clinical implications as well. And so we'll explore those in detail a little bit further in the lecture. And so by understanding those causes and the various etiologies, you can better understand your approach to diagnosing and then tailoring your management strategies to the patient with cirrhosis based upon their etiology. All right. Moving forward, let's dive into the pathophysiology of cirrhosis a little bit deeper. And that's going to be very pivotal in understanding how that condition develops and progresses. The pathophysiological changes can be complex, but they can be broken down into several key processes. First, liver injury. Whether it's due to viruses, alcohol, or other causes, repeated injury to the liver is the initial trigger in the development of cirrhosis. each insult is going to result in the death of hepatocytes. And that's going to be, remember, the liver's functioning cells. And that's going to set the stage for further pathologic changes. So those further pathologic changes can include inflammation. So in response to hepatocyte damage, the liver is going to initiate an inflammatory response. While this is a normal part of healing, chronic inflammation can lead to harmful consequences, such as fibrosis and scarring. And that's a critical phase where the normal liver tissue begins to be replaced by scar tissue. In response to ongoing inflammation, the hepatic stellate cells become activated and produce extracellular matrix proteins, leading to fibrosis. Over time, the fibrosis becomes extensive, disrupting the liver's normal architecture and therefore its normal function. And then finally, we would observe regenerative nodule formation. The liver attempts to regenerate by forming nodules of hepatocytes. However, these nodules are irregularly arranged and they're surrounded by fibrous bands, which is going to lead to the distortion, again, of the architecture and therefore the function of the liver itself, which is going to be characteristic of cirrhosis. So it's important to note that these processes don't just happen in isolation. They're all interconnected, with one leading to the other in a vicious cycle that culminates in the development of cirrhosis. So understanding those mechanisms is key to grasping how different etiologies can lead to the same endpoint and how we might intervene therapeutically. So as we continue our discussion on the pathophysiology of cirrhosis, I'd like to focus a little bit on the liver's critical role in metabolism and how cirrhosis impacts these normal functions that we need. The liver plays a vital role in protein synthesis, particularly synthesizing albumin, which maintains oncotic pressure, and clotting factors, crucial for blood coagulation. Remember, those are particularly your vitamin K, 2, 7, 9, and 10, and then as well as proteins C and S. So in cirrhosis, the liver's capacity to synthesize these proteins, all of them, is compromised, leading to complications like edema and bleeding disorders, coagulopathies, due to the hypoalbuminemia and the impaired coagulation. Another key function is detoxification. The liver detoxifies harmful substances, including drugs and metabolic byproducts. Cirrhosis impairs the liver's ability to do this, which is going to cause the accumulation of toxins in the body. For instance, the buildup of ammonia, not cleared effectively by the cirrhotic liver, as well as other nitrogenous compounds, can contribute to hepatic encephalopathy. Regarding metabolism, the liver is central in carbohydrate and lipid metabolism. Cirrhosis disrupts those processes, and that's going to lead to metabolic imbalances. And that can affect glucose regulation, which can contribute to hypoglycemia, and it can alter lipid profiles. So those are all things to think about regarding metabolism in cirrhosis. Now, drug metabolism can be significantly altered by cirrhosis, and that can lead to prolonged drug half-lives and increased sensitivity to medications. So therefore, you may need to carefully dose your patients and adjust and monitor their reaction to those dose changes. There's also hormone metabolism that can be affected. The diseased liver struggles to metabolize hormones effectively, and that can lead to these imbalances. For example, impaired metabolism of estrogen can lead to features like gynecomastia and spider angiomas in men. For protein synthesis, as mentioned, the cirrhotic liver basically has a reduced ability to synthesize albumin and clotting factors. We have portal hypertension, which is a very, very well-known impact of cirrhosis. So one of the hallmark consequences of cirrhosis is portal hypertension, and that's going to be that increased pressure in the portal venous system. So all of that blood trying to drain into the liver because of the fibrosis kind of clamping down, those fibrosis and those nodules kind of clamping down on that low pressure system coming in can lead to that congestion. And so, again, that can develop or cause the development of varices, ascites, splenomegaly, and that's going to be a major challenge in the management of cirrhotic patients. You also have hepatorenal and hepatopulmonary syndromes, and these are examples of how cirrhosis can impact other organ systems. Hepatorenal syndrome involves renal failure due to circulatory alterations in advanced liver disease, while hepatopulmonary syndrome involves lung abnormalities leading to breathing difficulties, such as an effusion. So, understanding the impacts of cirrhosis on liver metabolism and other systemic functions helps us appreciate the complexity of the disease, how it can affect other body systems, and how it's going to take a multi-system approach and probably a multidisciplinary approach to really manage this condition very well. All right. Let's shift our focus to clinical manifestations. So, understanding the clinical features of cirrhosis is crucial for early recognition and timely management. Let's begin with some of the symptoms that are often reported by our patients. Fatigue, which is one of the most common complaints, is often multifactorial, but can impact the patient's quality of life significantly. We have weakness, so it can be this general feeling of malaise or weakness, and that's not uncommon, which is going to reflect the overall decline in bodily functions. Loss of appetite or anorexia is a frequent symptom as liver disease progresses. Patients may experience significant weight loss, partly due to anorexia and altered metabolism. So those are some of our clinical features. We can also look at some of the physical exam findings, such as jaundice, that yellowing of the skin and eyes, and that's going to be a clear sign of liver dysfunction resulting from the buildup of bilirubin. The spider angiomas, which are those small spider-like blood vessels visible under the skin, and those are typically found on the torso and the face, and those are linked to those hormonal imbalances caused by liver disease that I mentioned earlier, especially with regards to estrogen. Patients can get reddening of the palms or palmar erythema, and that's another sign of liver disease also related to hormonal changes. We can get ascites, which is something we talk about a lot, and that's that accumulation of fluid in the abdomen indicating advanced liver disease and portal hypertension, often portal hypertension. Hepatomegaly, so an enlarged liver, which can be detected on physical examination, and splenomegaly, which is often a consequence of portal hypertension. We can also detect that on our physical exam. You can also have this caput medusae, and that's this appearance of engorged periumbilical veins, and that's going to resemble the head of Medusa from Greek mythology, and that's a direct result of portal hypertension as well. So recognizing all of these signs and symptoms put together is key to diagnosing cirrhosis early in its course, as well as when these patients present acutely. So each of these clinical features can provide us with clues about the severity and the progression of the liver disease, and that can help guide us with our subsequent diagnostic and therapeutic approaches. Worth mentioning in this lecture are just a few signs of advanced disease, such as varices, or hepatic encephalopathy, or hepatorenal and hepatopulmonary signs. Those usually indicate a somewhat advanced disease in our cirrhotic patients. All right, let's dive into some diagnostic tests that can help us clinch our diagnosis of cirrhosis. These tests are going to be pivotal in monitoring the progression of cirrhosis and tailoring the management strategies accordingly. So firstly, we have LFTs, which are going to be fundamental in assessing the liver's functional capacity, and those can include the AST and ALT, and those are enzymes that, when elevated, can indicate liver cell injury. And so I want to take a second and say that an elevated AST and ALT can indicate, if they're high enough, can indicate this very acute hepatitis, but if they are just above the normal limit, then sometimes we refer to that as like a smoldering AST and ALT, and we see that sometimes in cirrhotic patients as well. But unfortunately, sometimes we also see normal ALTs and ASTs. So these aren't very sensitive or specific, but they can help you to put together a general clinical picture of what's going on with this patient. With regards to bilirubin, high levels of bilirubin can result in jaundice, as we discussed, and that can be a common sign of dysfunction. And then ALK-Phos, or alkaline phosphatase. And that's an enzyme that, when elevated, can indicate cholestasis, or blockage in the bile ducts, which could be a sequelae of cirrhosis. However, an elevated ALK-Phos can also indicate problems in bone. It can also indicate cancers. It can also indicate renal dysfunction. So there's a lot of other things that can cause elevated ALK-Phos. But again, it helps us to paint this large clinical picture with all of the data combined. So don't use any of these one tests just alone. Take the entire clinical picture. In terms of imaging, ultrasound is often a first-line imaging modality because it's non-invasive, and it's going to help in assessing the liver texture, detecting ascites, guiding interventions like paracentesis maybe. Computed tomography, or CT, is going to provide more detailed images, and it's going to be useful in diagnosing complications. Potentially, it can diagnose varices, it can diagnose hepatocellular carcinoma, so CT is also a tool that we can use. We also have MRI, and that's going to offer even more detailed images, and it's particularly helpful in characterizing liver nodules and assessing vascular anatomy. Lastly, in certain cases, a liver biopsy may be necessary. It's technically the definitive way to assess the degree of liver damage and fibrosis, helping to confirm the diagnosis and gauge the progression of cirrhosis. So each of these diagnostic tools provides valuable insights into the state of the patient's liver, and that can help us, again, not just in diagnosis, but also in detecting and managing complications effectively and early. Okay, so let's talk a little bit more in terms of specifics of the diagnosis of cirrhosis, especially considering its varied etiologies. Because each cause of cirrhosis has specific diagnostic tests that may help, we should talk about each of those separately. Starting with Wilson's disease, again, that genetic disorder leading to copper accumulation. So we can measure serum ceruloplasmin, and we can perform 24-hour urinary copper tests. So a low ceruloplasmin and a high urinary copper are indicative of Wilson's disease. We can do a slit lamp examination, and that can be performed to detect the Kaiser-Fleischer rings, and that can be a hallmark sign of copper deposition in the eyes. You can also do a liver biopsy for quantitative copper measurement, which can also help to confirm the diagnosis. With regards to hemochromatosis, again, that genetic condition with iron overload, we can assess serum ferritin and transferrin saturation levels with elevated levels suggesting iron accumulation. We can do HFE gene testing, which is crucial as specific mutations are associated with hemochromatosis. And then in some cases, again, a liver biopsy for quantitative iron measurement is necessary. In the case of autoimmune hepatitis, we can look for specific antibodies, including ANA, SMA, LKM1. Those are all specific autoantibodies that we can look for in patients with cirrhosis. We can look for elevated IgG levels, and that can be a characteristic feature of this condition. And then for viral hepatitis, you can do and often will do serologic testing to help you identify hepatitis viruses B versus C versus some of the more rare ones like D and E. And then polymerase chain reactions for the viral load and assessment provides information about the activity and transmissibility of the virus itself. So those diagnostic methods are tailored to the suspected underlying cause of cirrhosis. Now, let's transition from diagnosis to some general management. So let's address kind of just some general principles in the management and treatment of cirrhosis. And that can encompass a very broad range of strategies, from preventative measures to lifestyle modifications to actual management of complications. So preventative measures are crucial in cirrhosis. Vaccinations can play a pivotal role, especially against hepatitis A and B, to prevent further liver damage. And then you can have, in the right patient population, screening for hepatocellular carcinoma, and that can be essential given the increased risk in certain patient populations. And that typically involves ultrasound exams as well as potentially serum alpha-fetoprotein testing. You can talk about, like I said, lifestyle modifications. So alcohol cessation is imperative in all cases of cirrhosis, regardless of the etiology. Even in non-alcoholic liver disease, abstaining from alcohol can prevent further liver damage, and therefore you should discuss that with your patients and make sure that they understand those things. Dietary changes, including a low-sodium diet, are important, particularly for managing ascites. Protein moderation or restriction may also be recommended in cases of hepatic encephalopathy in order to reduce the production of ammonia and other nitrogenous waste that may lead to hepatic encephalopathy. You can also manage the complications. I managed ascites earlier with a low-sodium diet. We can give diuretics for ascites. Particularly spironolactone is often prescribed for the management of ascites. We can do endoscopic treatments for variceal bleeding, and we can prescribe patients lactulose or rifaximin for hepatic encephalopathy. It's important to note that the management of complications is very dynamic, and it requires regular monitoring and adjustments based on the patient's condition as the condition is evolving. So, in summary, the general management of cirrhosis involves all three of these things: preventative, some screening, potentially, lifestyle modifications, and complication management. And the aim is to preserve liver function, prevent further damage, and improve the quality of life for our patients. All right, so building upon the general management strategies, let's talk about some specific management and treatment approaches tailored to the various etiologies of the condition. And we can start with viral hepatitis. For hepatitis B, the cornerstone of treatment can involve nucleoside or nucleotide analogs, such as tenofovir or entecavir, and those medications can suppress viral replication and can slow the progression of liver disease. In the case of Hep C, the treatment landscape has been revolutionized by some of these direct-acting antivirals, and those drugs offer a cure for most patients with hepatitis C, significantly reducing the risk of cirrhosis, progression, and complications. For Wilson's disease, the primary treatment involves chelation therapy using agents like penicillamine or trientine, which help remove excess copper from the body. Additionally, zinc is used to prevent the absorption of copper, or can be used to prevent the absorption of copper from the intestine, but I believe that's a less used treatment. For hemochromatosis, phlebotomy can actually be used as one of our treatment options, and that's going to regularly remove blood and help reduce the overall iron levels. And then in some cases, chelation therapy may be used as well for hemochromatosis, especially in patients who can't undergo phlebotomy for other reasons. Now, in cases of autoimmune hepatitis, we can give corticosteroids such as prednisone, which effectively reduce or suppress that immune response and therefore can reduce the level or degree of inflammation within the liver. In many cases, azathioprine is added as a steroid-sparing agent to reduce the side effects associated with long-term steroid use. And so that combination therapy is key in controlling the autoimmune process and preventing progression to cirrhosis. For patients with alcoholic liver disease, obviously we're going to talk about the most crucial step for these patients, which is going to be abstinence from alcohol. So that continued alcohol consumption can accelerate liver damage, and cessation is going to be the only way to halt the disease progression or slow it down at least. Along with abstinence, nutritional support is going to be vital, as many of these patients with alcoholic liver disease suffer from malnutrition, which needs to be addressed. Regarding non-alcoholic steatohepatitis or NASH and non-alcoholic fatty liver disease, the cornerstone of management is going to be weight loss and sustainable weight loss for our patients, and that can be achieved through dietary changes and increased physical activity when appropriate. So weight loss has been shown to reduce liver inflammation and fibrosis. Equally important is the management of other comorbid conditions such as diabetes, hypertension, and dyslipidemia. So all of these specific treatment modalities are tailored to address the root cause of cirrhosis in each patient, and by effectively managing those underlying conditions, whether it's viral hepatitis or Wilson's disease, hemochromatosis, or anything listed on this slide, we can significantly alter the course of the disease, we can prevent complications, and we can improve our patients' outcomes. All right, and then as the disease process of cirrhosis progresses, we can end up talking with our patients about the possibility of liver transplant. And that's often the last resort for patients with end-stage liver disease, and understanding its indications about the evaluation process, which is quite rigorous, and outcomes is going to be essential for any medical professional who may ever see any patient who has cirrhosis. So indications for transplant can include decompensated cirrhosis, which is characterized by complications such as refractory ascites, hepatic encephalopathy, and variceal bleeding. Hepatocellular carcinoma that meets very specific criteria may make the candidate suitable for transplant. And then in acute liver failure, some cases warrants urgent liver transplantation. And so, as far as the evaluation process goes, it's pretty comprehensive, as I mentioned, and it assesses not just the severity of the liver disease, but also the patient's overall health, their psychosocial status, the support system that they do or do not have. It's going to involve a multidisciplinary team, including hepatologists, transplant surgeons, nurses, social workers. All of these people are going to come together to ensure that the patient is suitable and prepared for transplant. With regards to outcomes, liver transplant can dramatically improve the quality of life and survival in patients with end-stage liver disease. Post-transplant, patients require lifelong immunosuppression to prevent organ rejection, along with regular monitoring for complications. And so there is one special niche topic, probably outside the scope of USMLE Step 2, but living donor transplantation is an option where a portion of a healthy liver is donated, typically from a family member, maybe a close friend, and that can reduce waiting times for a transplant patient and has pretty good outcomes both for the donor and the recipient. All right, so key takeaways. Remember that cirrhosis can present with a variety of symptoms ranging from fatigue and weakness to more specific signs like jaundice and ascites. So early recognition of those signs can be crucial for timely intervention. Keep in mind the common etiologies of cirrhosis, such as viral hepatitis, alcohol consumption, non-alcoholic steatohepatitis, non-alcoholic fatty liver disease, autoimmune hepatitis. And then also consider other etiologies, your more rare things like Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, PBC and PSC as well. And then manage those etiologies. Tailor your treatment based on the underlying cause. Think ahead about complications, so always be vigilant for complications of cirrhosis such as variceal bleeding, hepatic encephalopathy, ascites. Managing those complications effectively can significantly improve patient outcomes. Be sure to stay tuned for our next lecture, which is going to talk about the sequelae of cirrhosis a little bit more in depth. So some of those complications we've talked about, we're going to have a lecture really just on those. All right, and that's it. Thanks for tuning in. As always, please remember to like, comment, and or subscribe if you find our content useful or if you have any suggestions at all. We're always trying to improve over here. Thank you guys so much.